Welcome back to Core EM, where we dive into the core concepts of emergency medicine, and today, pediatric emergency medicine. I'm Ellen Duncan, and I'm joined by Dr. Noumi Chowdhury, one of our stellar senior emergency medicine residents. Noumi, it's so great to have you here.
Thanks for having me. I'm excited to dive into today's topic.
Today, we're discussing something that can be distressing for both families and clinicians, the diagnosis once known by the ominous name Apparent Life-Threatening Event, or ALTI, which has thankfully been updated to BRUE, or Brief Resolved Unexplained Event. This is one of those presentations that challenges even seasoned emergency physicians, so let's break it down. Noumi, can you set the stage with a case?
Absolutely. So you're working in a busy pediatric ED and get handed the chart of a 4-month-old ex-full-term, fully vaccinated boy who is presenting after an episode of unresponsiveness. According to the mom, he suddenly became pale and limp and was unresponsive for a brief moment. She stimulated him gently, and he quickly returned to his baseline.
That's definitely concerning as a parent and as a provider. What did his history, exam, and vital signs look like?
So his history was reassuring. He didn't have a fever, no respiratory distress, no cough, vomiting, diarrhea, or rash. He was feeding and voiding well. His vitals were also normal. He was afebrile with a heart rate of 140, respiratory rate of 30, blood pressure of 78/45, and oxygen saturation of 100% on room air. On exam, he was alert and well-appearing, with good color, flat fontanelles, and a normal cardiopulmonary and neurologic exam.
So to recap, it sounds like we've got a 4-month-old ex-full-term, fully vaccinated infant with an isolated brief episode of pallor, limpness, and unresponsiveness, who's now completely back to his baseline. What's at the top of your differential?
So this sounds a lot like BRUE. Remember, BRUE stands for Brief Resolved Unexplained Event, so it must be brief, fully resolved, and not explained by any other condition. BRUE typically affects infants less than 1 and is characterized by one or more of the following: cyanosis or pallor, irregular breathing, altered responsiveness, or a marked change in muscle tone, either increased or decreased.
So it's so important to remember that BRUE is a diagnosis of exclusion. You can't call something a BRUE if your history and exams suggest a specific diagnosis, like infection, seizure, or trauma.
Absolutely. Risk stratification is also critical. Patients with low-risk BRUE have to be at least 60 days old, with a gestational age at birth greater than or equal to 32 weeks, and post-conceptional age greater than or equal to 45 weeks. This must be the first episode, and it has to last less than 1 minute. The history and exam have to be reassuring, and the patient can't be given CPR by a trained professional. Patients who meet all of these low-risk criteria generally don't require extensive testing, and they can often be discharged with strict return precautions and close outpatient follow-up. It's important to note that only 6 to 15% of cases meet these low-risk criteria, though.
That's surprising. So most BRUE cases fall into the higher risk category, which requires more investigation. What are those high-risk criteria?
Any patients not meeting low-risk criteria fall into the high-risk category, as do patients with any concerning history of abuse, toxin exposure, or family history of sudden cardiac death. Abnormal findings on exam, like signs of trauma or abnormal neurologic exam, also move infants into the high-risk category. These patients require a more thorough evaluation and are often admitted to the hospital. Importantly, serious underlying conditions are identified in approximately 4% of high-risk infants.
Yeah, it's so important to keep a broad differential for these high-risk patients. In these cases, I personally like using the Misfits mnemonic.
It's a great tool for remembering all the things that could be going on with that sick infant. In this case, T stands for trauma, both accidental and intentional. H stands for the heart, which includes congenital defects and dysrhythmias. And E, M, and I stand for endocrine and metabolic causes, as well as inborn errors of metabolism. The first S stands for sepsis, F stands for formula, and I refers to intestinal catastrophes. Lastly, T and S stand for toxins and seizures, respectively. It's crucial to have a systematic approach to stabilize and assess the patient, especially for high-risk infants.
I couldn't agree more. Let's talk about the workup for these patients.
Always start with their ABCs, airway, breathing, circulation. Make sure to also check a point-of-care glucose. Patients should also be put on cardiorespiratory monitoring.
Sounds reasonable. So once you've gone through these first steps, what diagnostic workup are you getting?
In these patients, blood work and imaging studies are usually indicated. I would start with the venous blood gas, a complete blood count, and electrolytes. An EKG will help evaluate for cardiac causes, and a chest X-ray can look not only for signs of infection, but also at the size of the cardiothomic silhouette. If you suspect head trauma or seizure, or if anything on the history or physical exam set off your spidey senses, you should consider getting head imaging and an EEG. It's worth mentioning that only 6% of diagnostic tests contribute meaningfully, so testing should be judicious.
Absolutely. We generally try to avoid invasive testing in kids if possible. What about outcomes? What can reassure or worry parents and providers?
That's an excellent question. BRUE recurs in approximately 10% of cases, though historical ULTI cohorts had a recurrence rate of 10 to 25%. So return precautions should be clearly discussed. Mortality is under 1% and nearly always linked to identifiable diagnoses like child abuse, metabolic disorders, neurologic pathology, or severe infection. It's important to note that BRUE is not the same thing as SIDS or sudden infant death syndrome. BRUE peaks in infants under 2 months, while SIDS peaks between 2 to 4 months. BRUE typically occurs during daytime hours, whereas SIDS is most common from midnight to 6 a.m.
That's such an important distinction. So, Noumi, let's recap. Infants meeting low-risk BRUE criteria need minimal testing, but should absolutely have safety education and a clear follow-up plan. Patients with high-risk BRUE, on the other hand, require a more thorough workup because they may have a serious underlying condition. Any last thoughts?
Always remember, BRUE is a clinical framework, not an endpoint. You should investigate systematically and don't hesitate to reassess or admit if anything doesn't feel right.
That's great advice. Thank you so much for coming on the show to break down this tricky diagnosis.
Thank you for having me.
And thank you to everyone tuning in. Check out our show notes for a summary and see you next time on Core EM.